So we are going to start the influenza session, and Dr. Karen, if you can lead us off, please.
Good morning, everybody. I'm very pleased to be able to bring you some of the deliberations that the influenza work group has been involved in over the past several months. I'd first like to acknowledge our work group members. We have a very dedicated and very active work group, and they've had a lot to do in the last few months. I'd like to particularly acknowledge Lisa Grosskopf, our CDC lead. So what we've been working on, as you heard in February, the work group's primary activity has been to review the relative efficacy and safety of LAIV and IIV for use in children. We've had some additional consideration of the language for use of LAIV and IIV when both are available. We've also reviewed some data on use of LAIV and IIV in children with high-risk conditions, including children with a history of asthma or wheezing. We've also discussed the dose algorithm for children aged 6 months through 8 years, particularly in this year where there is not a strain change. And we've also finalized the draft of the 2014-2015 ACIP influenza statement. So the first presentation today, there is a parallel group, the Novel Influenza Vaccine Work Group, which is chaired by Dr. Doug Campos-Alcalt, who will give the first presentation. Maria Cano will give an influenza vaccine safety update. We're very pleased to have Melissa Stockwell here from Columbia University, who under a CISA grant will present some work on assessing fever rates in children following LAIV and IIV. And then Lisa will present our data on LAIV and IIV for children ages 2 through 8 years, followed by the proposed recommendations. So, Doug.
All right, thank you. Good morning. This is going to be a real quick presentation. We've had a work group on novel influenza for a couple months now, been meeting regularly. Our charge is very limited. It's to develop recommendations for the use of influenza A H5N1 vaccine during an inter-pandemic period. There are currently 4 vaccines in the national stockpile, 4 different H5N1 vaccines. However, only 2 of those have been licensed for general use, and only one, the GSK vaccine, is actually going to be available for use. The use of the stockpile vaccine is limited to a pandemic, and inter-pandemic use is not possible. So the GSK vaccine will be produced in small volume, or in 100,000 doses or so, will be produced and stored somewhere, and some of these will be at NIH, probably the rest at the manufacturer themselves. But these doses will be available to high-risk investigators and other high-risk groups, and we're going to focus on making recommendations for its use in that very limited group of people. So we'll focus on this one vaccine and identifying the target audience. Our plan is to do the grade analysis over the next couple of months and identify the high-risk groups and draft some recommendations. Now, our plan was to bring recommendations to the group in October, but having heard the just previous discussion on yellow fever, we'll probably come back with the grade recommendations, some language to discuss, and then come back in February probably with the recommendations. So that's our plan currently. Thank you. Oh, one other thing. I do want to acknowledge Sonia Olson, who's the staff person for this. I did not do that last time, and I regretted it. Not that she made me regret it. I felt bad not acknowledging her because she does all the work. So Sonia, thank you very much for all your work.
Good morning. Good morning. I'll be presenting the end of season flu vaccine safety update for 2013 to 14. Let's see. I'll provide, let me just go here. I'll provide updates from Vaccine Adverse Event Reporting System and Vaccine Safety Data Link Surveillance. However, before I present the results, I'd like to go over the strengths and limitations of VAERS. Most of you have seen this slide in previous presentations. Some of the strengths are rapid signal detection, including those of rare adverse events, while some of the limitations are reporting bias, inconsistent data quality, and completeness. Another limitation of VAERS is illustrated on this slide. Of the total population, only individuals who were vaccinated and had adverse events that were reported to VAERS are included and shown in the pink cell. VAERS data do not include those in the white cells, which are unvaccinated comparison group, those vaccinated but had no adverse event, or had not reported to VAERS. Given this limitation, VAERS is not able to calculate rates of occurrence of adverse events, determine increased risk, or calculate vaccination coverage. This table, which I had presented in February, summarizes the licensed flu vaccines that became available during this current season. There was the complete switch to quadrivalent live-attenuated flu vaccine this season, so comparison between trivalent and quadrivalent forms will be between seasons. For the inactivated flu vaccine, both trivalent and quadrivalent vaccines are available, and comparison can also be made within the current season. The second column shows the abbreviations which I'll be referring to during this presentation. The last column shows the recommended age groups for the vaccines listed. VAERS surveillance includes U.S. reports after IIV and LAIV with receipt and vaccination dates from July 1, 2013 to May 2, 2014. Signs and symptoms or diagnosis are coded into the VAERS database using the International Medical Dictionary for Regulatory Activities, commonly referred to as MEDRA. MEDRA terms are not mutually exclusive, and a report may have several different MEDRA terms. We reviewed medical records for all serious reports after the recently licensed flu vaccines that I had listed in the previous table and Fluzone intradermal. We also reviewed pregnancy reports for spontaneous abortion, stillbirth, congenital anomalies, those classified as serious, and all reports of anaphylaxis with a history of egg allergy. FDA conducted empirical Bayesian data mining to detect disproportional reporting in the VAERS database. This slide summarizes U.S. reports to VAERS following IIV for all ages. This is a comparison between IIV4, shown in the last column, with IIV3 this season and the previous season, which are shown in the middle columns. There were 493 reports for IIV4 and approximately 7,000 or so for IIV3. Most of the reports were classified as non-serious. It's important to look at the percentages rather than the actual numbers when comparing the results. GBS was comparable for IIV3 and IIV4. Anaphylaxis was higher for IIV4 compared to IIV3 from the previous and current seasons. However, there was no disproportional reporting in data mining for GBS or anaphylaxis for the last season and the current season. This slide summarizes the results for LAIV. This is the comparison between LAIV4 from this season to LAIV3 from last season. There were 486 total reports for LAIV3 compared to 657 for LAIV4. The percentages of serious reports and anaphylaxis were higher for LAIV3. GBS was comparable for both LAIV3 and LAIV4. There was no disproportionate reporting in data mining for GBS and anaphylaxis. This next slide shows a summary of the results for flu zone intradermal. There were 243 reports, with 3% classified as serious. 20% were in males. The median age was 44 years, with a median onset interval of 1 day. The top 5 MEDRA terms are listed, and they are mostly injection site reactions. There was no new data mining findings for flu zone intradermal this season. This slide shows the results for Flucelvax, which is a cell culture-based inactivated flu vaccine. There were a total of 167 reports, 3% of which were serious, 46% were in males. Median age was 36 years, with a median onset interval on the day of vaccination. The most common MEDRA term is drug administered to patient of inappropriate age. The recommended age is 18 or older. However, 37% of the reports were in less than 18 years of age. Other common adverse events were pain in the extremity, injection site pain, rash, and nausea. This is a summary for Flublok, which is the recombinant trivalent inactivated flu vaccine. There were 20 VAERS reports, and none were considered serious. All were in females with a median age of 47 years, and onset interval, the mean was on the day of vaccination. Pruritus was the most common reaction comprising 35%, followed by dyspnea, headache, erythema, and rash, 18% each. The slide summarizes the pregnancy reports in VAERS following flu vaccination. There were 61 reports following IIV. Median age was 30 years, with a median gestational age at vaccination of 18 weeks. The pregnancy-specific outcomes are listed here, with 5 cases of spontaneous abortion. 31, or approximately 51%, were non-pregnancy specific reports. 19 of the reports had no adverse events. There were 22 reports without any adverse events after LAIV4, and 1 serious report, which was a case of pulmonary hypertension in an infant whose mother received LAIV4. There was 1 case of anaphylaxis report in VAERS after flu vaccination in a person with a history of egg allergy. A 4-year-old male developed diffuse hives, watery eyes, sneezing, and vomiting within 15 minutes after IIV3. He had allergy testing after the reaction, which showed positive skin prick tests for egg extract and gelatin, and positive serum test for egg white and bovine gelatin. His past medical history included periorbital rash after ingestion of meringue icing, which has egg whites, and increased salivation, abdominal pain, and weakness after ingestion of gummy candies and marshmallows, which have gelatin. This case was reported in the literature, and the authors concluded that the reaction was most likely related to gelatin rather than egg protein in the vaccine. I'll now present the findings from the vaccine safety data link for this season. This is the 6th season that real-time rapid cycle analysis have been conducted within VSD, RCA for the age groups indicated is performed for the pre-specified outcomes using ICD-9 codes listed on this slide. With the exception of anaphylaxis, the outcomes are neurological adverse events. For 2013 to 14 flu vaccine, RCA used automated data from approximately 9.3 million patient records. This slide shows the data for RCA during the current season. As of April 11, 2014, there were approximately 3,800,000 IIV3 doses of dose 1 administered. This total does not include Fluzone high dose and intradermal, but does include cell culture-based and recombinant IIV3. There were approximately 219 doses of LAIV4, dose 1 administered. There have been very limited uptake of IIV4, cell culture-based and recombinant trivalent vaccines in VSD surveillance. There were no signals in RCA during the season for any pre-specified outcomes. In summary, there were no new safety concerns detected for inactivated or live-activated flu vaccines during the season in VAERS and VSD surveillance. Surveillance for the next season will include enhanced safety monitoring for quadrivalent IIV and LAIV vaccines, the cell culture-based and recombinant IIV3 vaccines, pregnancy reports, looking specifically at the complications that I had mentioned earlier, reports of anaphylaxis in persons with history of egg allergy after flu vaccine, and finally, reports with history of asthma or wheezing after LAIV4. I'd like to thank those on the previous slide, especially Penina Haber and Pedro Moro, who assisted in the preparation of this presentation, and also Paige Lewis and Eric Weintraub for the automated VAERS and VSD data. Thank you.
Thank you very much. I think we'll move on to Dr. Stockwell and discussion on fever, and then we can have some questions after these two presentations.
Thank you for inviting me here today. I'm going to tell you about a study that we conducted assessing fever rates in children who are 24 to 59 months old after receiving live-attenuated influenza vaccine or inactivated influenza vaccine during the 2013-14 season. The study was conducted by our CISA Center through a contract from the CDC. I'd like to acknowledge our co-investigators and study team from Columbia as well as the CDC, and we have the following disclaimers and disclosures. So live-attenuated influenza vaccine is potentially more effective than inactivated influenza vaccine in children, and therefore characterizing fever rates after LAIV and IIV, both with and without simultaneous vaccination, may help inform national policies for pediatric influenza vaccination. And that includes an evaluation of quadrivalent influenza vaccines as they are introduced. So one previous study in children suggested higher fever rates in children in the day 0 through 10 period after receiving LAIV versus IIV. That was particularly on day 2, where the fever rates were 5.4% in those receiving LAIV versus 2% in those receiving IIV. And therefore, the risk interval for LAIV was thought to be from the day 0 to 2 period. In contrast, the risk interval for fever after IIV in a previous study was shown to be the vaccination day and the day after vaccination, or the day 0 through 1 period. So text messaging can be used for public health surveillance and prevention efforts, such as reminder week calls for vaccination. And we successfully used it to assess rates of fever after simultaneous vaccination with IIV3 and 13-valent pneumococcal conjugate vaccine, and decided to employ this method in this study as well. So our primary objective was to assess the rates of fever in 24 to 59-month-old children receiving LAIV compared to those receiving IIV. Our primary hypothesis was that fever rates in the risk window of the day 0 to 2 period post-vaccination would be higher in those receiving LAIV versus IIV, with that day 0 to 2 period being defined as the vaccination day and the first 2 days post-vaccination. And we selected that risk window based on those 2 previous studies that I mentioned. And our secondary hypothesis was that fever rates in the non-risk window, or day 3 through 10 period, would not be significant difference in those 2 groups. We had a number of secondary objectives. One was to assess whether fever rates in the day 0 to 2 period would be higher in those children receiving IAV4 versus IAV3, to characterize the clinical importance of the reported fevers with respect to height of fever, occurrence of medically attended fever, and associated medically attended health outcomes, as well as to explore whether fever rates after vaccination were different in those children receiving LIV either simultaneously with other vaccinations or alone, but I won't be focusing on that objective. This was an observational prospective cohort study that was conducted between September 2013 and April 2014. Patients were recruited from the Columbia University Medical Center, New York Presbyterian Hospital clinical sites at the time of vaccination. Vaccination decisions were made solely by the healthcare provider caring for that patient. We did not randomize them to which vaccine to receive. And receipt of other vaccines was not an exclusion criteria. This study was approved by the CMC Institutional Review Board, and the CDC IRB relied on the determination by the CMC IRB. Families were recruited, then they were consented, completed an intake form, enrolled via text message, and then were trained in the use of a temporal artery scanner thermometer. To be eligible, children had to be 24 to 59 months old, have a visit at the study site during the study period, be receiving their first dose of LIV or IAV that season, and they had to have a cell phone with text messaging capabilities, which nearly everyone does, and the parent has to speak English or Spanish, which are the primary languages at our clinical sites. We had a number of exclusion criteria. I'm going to focus on the first three. So if the child had a chronic medical condition that was considered a contraindication or precaution to LIV, they were not enrolled. The exception was for children who had a history of asthma or wheezing, except if they were currently on an oral or other systemic steroid or used one in the past month, they were not eligible. Or if they were currently using an inhaled steroid or used one in the past 2 weeks, they were not eligible. And you can see the other exclusion criteria here. Families were sent a text message on the day 0 or day of enrollment at 8 p.m. that night, and then subsequently for the next 10 days at 8 p.m. each night. The information we collected was temperature range, actual temperature, and time taken, if any antipyretic medicine was given, and the name and time, as well as care sought at the clinic or emergency department. But I'll be focusing on our medical abstraction rather than this variable. Here's just an example just of the first text message that we sent, for interest's sake. We review each response the next morning, do daily review of responses. We identify non-responders, initiate phone contact, and troubleshoot any problems, as well as collect any unreported temperatures. We also ask families to use a paper diary and to send it back to us at the end of the 10 days. We conducted a chart abstraction for medically attended visits in the day 0 through 10 period post-vaccination for any ambulatory care, emergency department, or hospital visits to our NYP or CMC system. We abstract chief complaint, final diagnosis, review of symptoms, and any documented temperatures. And we verify other vaccines, either single or in combination, given at the time of enrollment, using our electronic health record, which includes our own immunization registry. For our definitions, day 0 was defined as the time period immediately after vaccination to the response to the text sent at 8 p.m. on vaccination day. And day 1 through 10 was the response to the text sent at 8 p.m. the night before to the response sent that night at 8 p.m. We looked primarily at any fever, so temperature greater than or equal to 100.4, but also assessed moderate fever over 102.2. And we looked at 2 time periods, day 0 through 2 and day 3 through 10. There were 991 patients who were approached, of which 642 were eligible. Of those, 535, or 83.1%, were patients were enrolled and analyzed. Of those, 309 received IIV, 226 LIV4, and all of the LIV was LIV4 this past season. And of those who received IIV, 211, or 68.3%, received the trivalent form, and 31.7% the quadrivalent form. This is the age of our enrollees. You can read the table across. So looking at those children who received the trivalent form of IIV3, about almost 2/3 were 2 to 3 years old. Those receiving IIV4, 60% were 4 to 5 years old. We didn't have the quadrivalent product available for children under 3 at our sites. And LIV4 was more evenly split between the 3 age groups. This is our information from all sources. So the black is via text message, the light gray via card, and the darker gray via phone. And you can see that primarily our information came from the text messages, and we had a good response rate, particularly on the day 0 through 2 period. So first assessing fever rates during the risk window. So this is day 0 to 2 period for temperature greater than or equal to 100.4. Those children who received the IIV, 5.8%. had a fever on 0 to 2 days post-vaccination compared to 3.8% of those receiving LAIV, and that was non-significant difference. Breaking down those receiving IV3 versus IV4, 5.2%. Those receiving IV3 had a fever compared to 7.1% receiving IV4. And again, that was a non-significant difference. Of note, of the 4 of the 22 fevers were temperature greater than or equal to 102.2, and none of them were in the LIV group. Now looking at the non-risk window, so day 3 through 10, again, temperature greater than or equal to 100.4. 9.9% of children who received IIV had a fever compared to 10.4% receiving LAIV, and again, that was non-significant. And further breaking down, those receiving IV3, 11.8% had a fever compared to 6.3% receiving IV4, compared to the same 10.4% receiving LIV4, and again, that was non-significant. And of note, only 10 of the 33 fevers included temperature greater than or equal to 102.2, and 6 of those were in the LIV4 group. Now looking at co-administered vaccines, in all the groups, the majority of children received influenza vaccine alone, not with another vaccine. But the most common other co-administered vaccines, in 82.6% of those who received a co-administered vaccine either received DTaP and IPV together as a combination vaccine or hepatitis A. We conducted a regression model looking at the risk window of day 0 through 2 of the temperature greater than or equal to 100.4. It was a log binomial regression which we adjusted first a priori for hepatitis A vaccine and Kinrick's co-administration, since those were the most commonly co-administered inactivated vaccines. We also adjusted for concurrent PCV13 vaccination. As I mentioned, there was an historical association with fever and PCV13 and influenza co-administration, as well as age group and then previous receipt of influenza vaccine. Other variables that we considered but didn't include based on a non-significant p-value of greater than 0.1 with a bivalent association with temperature greater than or equal to 100.4 were ethnicity, gender, enrollment month, and high risk for influenza. So looking at the adjusted model, in risk windows day 0 through 2, temperature greater than or equal to 100.4, the adjusted relative risk of LIV versus IV was 0.6, and that was non-significant. We also conducted a number of sensitivity analyses. We assessed just those children who received influenza vaccine alone. We removed those who received an antipyretic medicine within 8 hours before the temperature that was reported was taken. We looked at only data reported via text message and not via another form, and we limited analyses just to those greater than or equal to 3 years old, and the adjusted relative risk stayed the same in all those analyses of 0.6. On our medical record review, first looking at all participants from day 0 through day 10, there were no febrile seizures or hospitalizations documented. There were 9 ER visits and 17 ambulatory care visits. And then looking at participants with fever in the day 0 through 2 period, of those 22 cases, there were 2 children who had an ambulatory care emergency room visit. And just as a correction from the paper, they were both IV received IV4 in one case, who had an ER and an ambulatory care visit, and IV3 and hepatitis A in the other case. So in summary, there were no significant differences in fever rates, temperature greater than or equal to 100.4 on vaccination day or in the first 2 days post-vaccination with LIV4, with rates of 3.8% versus 5.8%, and that non-significance continued even after adjusting in regression models. There were few fevers temperature greater than or equal to 102.2 in any study group, with 4 of them being in IIV and 0 in LIV4. There are also no significant differences in fever rates in the 3 through 10 day period post-vaccination after LIV versus IIV, and there were no hospitalizations or febrile seizures in the day 0 through 10 period post-vaccination with any influenza vaccine. And our data analyses are still ongoing. Thank you.
Thank you very much. Are there any questions? Dr. Harrison.
I'm not sure if I missed this, but can you comment on the statistical power of your study to find differences?
Sure, yeah. So, yeah, I didn't include that. So we were powered to find about a little under the twofold difference between the studies. But so even with a absolute difference of 2%, we wouldn't have been powered to find a difference. But I think, considering that the rates are so small.
Dr. Kemp.
Yeah, so just following up on that, you broke it down by high fever for the first 2 days, but not for the 3 to 10. And it looked like it was a third versus a half for the 3 through 10. And I'm wondering if you could specifically.
Here, this one?
Okay, so it's 6 out of 14?
Six, right, so,
Is that right?
so the LI group would have been 6 out of 14 versus 4 out of 19 for day 3 through 10 period.
Oh, 4 out of 19.
Yeah.
Okay. So, I mean, I think the issue there is whether that you have enough statistical, power
Right,
to
and so
talk
we
about
actually
that difference.
didn't, so for the day, particularly for this study for the 102.21, we weren't looking at, I didn't have the slide here, but if we look at greater than or equal to 102.2, we don't have statistical significance. So we not statistical significance, we don't have enough cells to be able to look at that, and so that's why we're reporting it just as the raw crude data of 4 fever rates over 102.2 rather than showing that statistical change for the moderate fever. So we're focusing on the 100.4 fever.
Other questions? Thank you very much. Dr. Harris, or Dr. Rubin.
From the previous speaker, I just wanted a clarification. Is that possible? And the question was for the cell culture-based vaccine, the flu cell block, the ones that are under 18 years of age. Did they have, just to clarify, they were reported because it was given into an incorrect age group, not because they have some excess and adverse effects?
No, they did have some adverse events. So that was, and when we looked at the demographics, the information on the VAERS form, they had, they were less than 18 years of age. So I don't have the specific, I don't know if Dr. Morrow has more details on those specific cases. He's stepping up to the microphone since he had reviewed those specific cases.
Actually, those that received Fluzilvax and should not have received Fluzilvax were less than 18 years of age. The majority of those did not have an adverse event, and those that had an adverse event were mainly local injection site reactions. And the reason for reporting was because it was the incorrect age for administering the vaccine.
Any other questions? Thank you.
Okay, we'll move along. I'm supposed to also remind our presenters that we have simultaneous Spanish translation going on, so speaking clearly and speaking slowly is worthwhile.
I shall do my best. Good morning. Okay. So this presentation is in two parts. The first part is going to go over some information pertaining to LAIV and IIV for children who are not healthy, that is, children who have high-risk conditions that confer higher risk of bad outcomes or severe disease from influenza. And then after that, I'm going to briefly review some of the material that we went over at the ACIP meeting in February 2014 related to the grade analysis for these vaccines among healthy children. Before beginning, I just want to thank some folks who have been pretty integral to getting all of this prepared. Really appreciate all your efforts. So as mentioned, and probably as many of you remember, back in February, we had a number of presentations related to grade analysis of LAIV and IIV for healthy children. And by healthy, what we mean in this particular sense is children who do not have chronic medical conditions that confer a higher risk for severe outcomes due to flu infection. We did present several age groups worth of data, although we focused primarily on children 2 through 8 years of age. Just a reminder that the rationale for the selected age group was that, for one thing, LAIV is not licensed for children under the age of 2. And for the upper limit, 8 years is the upper limit of the age range for consideration of whether 1 versus 2 doses are needed. And that was selected a priori prior to the evidence review for programmatic consistency and simplicity of the recommendations we were eventually going to formulate. The grade assessment was presented for healthy children at the February 2014 ACIP, and during the discussion question period after that presentation, there were some questions that arose regarding the use of LAIV for children with chronic medical conditions. And when we initially planned our work, we had decided that we were going to tackle the literature on healthy children first, but since the questions came up, we've done a bit of a review, and I will say up front that this is still something of a work in progress, but because these questions were asked, I just wanted to be able to go over some of it with you. So for the first part of things, just by way of background, ACIP currently does not recommend the use of LAIV, the live-attenuated influenza vaccine, for children with asthma or with other chronic medical conditions conferring high risk of complications. Also, by way of background, the 2013-14 package insert for LAIV, so this is now Flumist quadrivalent, which was licensed a couple of years ago and is on the market for the first time this past season, 13-14, has a couple of bullets in the warnings and precautions section. Children younger than 5 years of age with recurrent wheezing and persons of any age with asthma may be at increased risk of wheezing following administration of Flumist quadrivalent. A second bullet, the safety of Flumist quadrivalent in individuals with underlying medical conditions that may predispose them to complications following wild-type influenza infection has not been established. And those just come from the warnings and precautions section. They're not strictly speaking contraindications, but that's where those bits of information are. So in review of comparative studies, we again, similar to the review that we did for healthy children, we sought to evaluate studies that compared the two vaccines, so not one or the other versus placebo, but studies that had an LIV arm and an IIV arm. And they may or may not have had placebo in addition, but they had to have both of those arms. So we have three studies. Ashkenazi et al. And Belshi et al. are maybe familiar because we discussed these quite a bit during the Healthy Children review. These are studies of relatively younger children, one 6 through 71 months, the other 6 through 59 months. They did not have as inclusion criteria the stipulation that the child had to have asthma or wheezing, but there were children that had either asthma, wheezing history, or an asthma diagnosis in both of those studies. In addition, there's also Fleming et al., which was published in 2006. This is a study specifically of children with an asthma diagnosis. It's by and large older children, 6 through 17 years. And for that reason, since for the time being we're focusing down on the younger age group, we are not going to be presenting information for that trial, but we'll probably be returning to it later at some point. So I'm going to present just a few slides from some of the grade and the forest plot information on the information for these children with a history of asthma or wheezing. We're dealing again with Ashkenazi 2006 and Belshi 2007. These are two studies that compared LAIV and IIV. Ashkenazi was an open label study. Belshi was a placebo-controlled blinded study. It had placebo both for LAIV and for IIV, so two matched placebos. Belshi is somewhat of a larger study than Ashkenazi. The data for these two studies subsetted out for the children who were between 24 and 59 months of age and also who had a history of asthma and or wheezing are actually broken down very nicely in a paper published by Ambrose et al. In 2012, which is where the information that you're going to see comes from. This first slide is our primary efficacy endpoint, lab-confirmed influenza, which was a critical outcome for us. We did not downgrade here for any of the parameters, risk of bias, inconsistency, indirectness, or imprecision. We have a relative risk of 0.53, which is significant with a 95% confidence interval of 0.38 to 0.73, and an estimated risk difference of 47 fewer cases per 1,000 with LAIV. The 0.53 risk ratio actually corresponds nicely with the one obtained last February when we presented this for the whole group of kids, not just those with asthma and wheezing, which was 0.47, so it's relatively comparable. Overall evidence quality is high. The next couple of slides have to do with wheezing outcomes, and the Belshi paper is the one we're looking at here. The definitions for the wheezing outcomes differed somewhat between Belshi and Ashkenazi, and for reasons of trying to be consistent, we're going to stick with Belshi for now. For this paper, medically significant and medically attended wheezing outcomes were both reported. So I'm not going to present both of those. We did look at both, and they look pretty similar. This is medically significant wheezing that we have a couple of slides on next. So this is protocol-defined medically significant wheezing, 24 through 59-month-olds, follow-up period of 42 days, 6 weeks after vaccination. We downgraded for imprecision here on the basis of the confidence interval, including 1, and also being fairly wide. We have a risk ratio of 0.69 with a confidence interval that's not significant at the 95% level. And we have overall evidence quality of 2 or moderate for downgrading for imprecision. This is the same scenario, 42 days follow-up, 24 through 59 months, and it's again just Belshi. This time it's children with asthma and or wheezing, but the further subdivision, children who have not wheezed in the last 12 months. Of course, our N gets a little smaller, so we have a wider confidence interval, which again includes 1, downgraded again for imprecision, overall evidence quality of 2 or moderate. And this is the children who have wheezed in the last 12 months. Again, this time we have an insignificant risk ratio and confidence interval downgraded for imprecision. We called this moderate quality evidence. This last one is the children that had an asthma diagnosis, and this is the smallest subset. We're now down to, in this study, only 120 to 130 kids per arm, so you can see how thin our confidence interval gets. The one difference here, this is the one instance where the point estimate is on the other side of 1, but it is still also is not significant, fairly wide at 0.29 to 1.88. Because of that downgrade, we estimated it as moderate quality evidence. So we also looked at some studies, tried to find studies involving head-to-head comparisons of the 2 vaccines for kids with other chronic medical conditions, and we're not able to find a lot. Again, this is preliminary, and we will be looking again. But we have a total of 4 papers briefly summarized here, 1 of children with cancer, 2 with cystic fibrosis, and 1 of children with HIV infection. If you look at the 5th column over from the left, the N, we're talking about fairly small studies here, so things are going to look very different when we ultimately summarize this. We don't have as the same situation with a couple of large studies as we did previously. So this is something that we will likely be coming back to later, but at this point we did not feel that there was sufficient evidence to move forward with anything for children with high-risk medical conditions or asthma. So some limitations to what I just presented. Studies are not powered to detect differences in wheezing asthma outcomes among the subgroup of children with a history of these conditions. We have wide confidence intervals, as you saw. The data, if one looks at the definitions for how the criteria for wheezing and asthma were described in the studies and how the data are reported, they really don't seem to clearly indicate a degree of asthma severity or wheezing severity for which LAIV benefits would outweigh risks. And this becomes important when we try to formulate a recommendation, of course, because we want to be able to say, please use this vaccine in this context and be able to be as clear as possible about what we mean by severe asthma or severe wheezing. And it's a little difficult right now for us to do that. The data that I presented had a follow-up time of 42 days, which is a little bit long after vaccination, and we don't have earlier outcomes. We have few comparative data at this point for other chronic medical conditions. So with that being said, we're going to move forward, and I'm going to go to the next part of the presentation now, which involves healthy children. We have not proposed any language changes for the upcoming season, any significant ones anyway, for high-risk medical conditions. So with that said, I know we went over a lot of this last time, but I'm going to review some of the tables and give a summary at the end for what we've done for the analysis for healthy children aged 2 through 8 years. And we will be focusing on 2 through 8 years here. This is just a reminder of the outcomes that were considered. All of them are listed here that were discussed with the influenza work group when we began this process. We have benefits, the efficacy outcomes, and harms, the safety outcomes. For our benefits outcomes, laboratory confirmed influenza, influenza-associated mortality, influenza-associated hospitalizations, and medically attended acute respiratory illness, or MARI, were valued as critical by the work group. We unfortunately were not able to find any evidence from our studies on influenza-associated mortality, so that's not presented in our results. Influenza-like illness and influenza-associated acute otitis media were both considered important, and we do have data for those. For harms, we had a bit more of a list. Medically attended wheezing was one of the critical ones. We added subsequently medically significant wheezing because there were data on that, and we thought that that might be useful, so that's part of why you saw that earlier. And then also immediate hypersensitivity and anaphylaxis, febrile seizure, and Guillain-Barré syndrome. Those were all critical. For immediate hypersensitivity, anaphylaxis, febrile seizure, and Guillain-Barré syndrome, these are sufficiently rare outcomes that we were really not able to make an assessment. There were also 3 listed as important: respiratory symptoms, other neurologic outcomes, and fever. We did include fever, respiratory symptoms, and other neurologic outcomes. We did not include in the evidence profile. They were not really defined specifically enough to really make it feasible to assess. And also they were important, and we had many other outcomes. They weren't considered critical, so we did not use those. Because we had a couple of serious outcomes that were rated critical that we couldn't really assess, we did include any related SAE. I have not included a value for this because this is quite a disparate bag of different kinds of events that occur, and it's really difficult to assign a value to it because there's so many different sort of events that could be rated as an SAE, but we did assess that. I'm not going to go through all of the tables and charts that we did last time because that's probably not necessary and it would take a lot of time. I do have them at the back of the set for extra slides should anyone want to see something in particular. But I'm going to go over the ones that either had a significant result or were critical safety outcomes in the next few slides. So for laboratory confirmed influenza, a critical outcome, this is data from Ashkenazi and Belshi. As mentioned earlier, one study is open label. The Belshi was blinded. This is data that's restricted to those in both studies that were over 24 months of age, so we don't have the 6 through 23-month-olds in here. We did not downgrade for any serious concerns. The risk ratio is 0.7 with a confidence interval of 0.38 to 0.58, and the overall evidence quality we termed high. Risk difference is estimated to be 46 fewer cases per 1,000. There we go. Okay, the other outcome that showed a significant difference in favor of LIV was influenza-associated otitis media. Similarly, we did not downgrade here. It's the same 2 studies, Ashkenazi and Belshi. Risk ratio 0.47, 0.3 to 0.73 is our confidence interval. We rated this overall as high quality evidence. The other critical outcomes, medically attended acute respiratory illness, hospitalization, and influenza-like illness did not show significant differences. And we'll see them a little bit on the summary slide at the end. This is one of our slides. We have several of them on medically significant wheezing. We are using Belshi only because of being able to keep the definitions of the wheezing outcomes consistent. This is the medically significant wheezing outcome. Again, follow-up time of 42 days. This is 24 through 59 months for the age of the children. We still have, even though we have a slightly larger group of kids in this particular slide, a relatively wide confidence interval and have downgraded for imprecision. Our overall quality is moderate. I should have mentioned also that last slide, let me just back up, was after dose 1. Children in the Belshi study could have been vaccine naive or not, so data are reported after dose 1 for both previously vaccinated children, which are here, and vaccine naive children, which are here. Similarly, we downgraded for imprecision and called it as moderate quality evidence. This slide is a summary of the outcomes for which we had information. Again, there were, for example, influenza-related mortality and several of the safety outcomes that we did not have adequate data for. The 2 lines highlighted in green, lab-confirmed flu and otitis media, are the outcomes for which there was a significant difference in favor of LAIV. The other outcomes, there was no difference. The first 5 outcomes listed are the benefits outcomes, the efficacy / effectiveness outcomes, and they're all listed there. If we take the lowest quality evidence of the critical outcomes as our overall quality, that would be hospitalization at evidence quality 3. We elected to take the quality as 2 and count the lowest as MARI rather than hospitalization. The reason for that being we had wanted to evaluate influenza-associated hospitalizations, but the hospitalization data that we had was actually not influenza-associated hospitalization, so we had downgraded that one for indirectness. We had some discussion of that at the last ACIP, and because we do have another critical outcome, which is lab-confirmed flu, for which we do have a specific outcome because it's lab-confirmed, we are not using hospitalization as our lowest. The lowest of the whole group then ends up being MARI, which is 2. For harms, we have medically significant wheezing, fever, and any related SAE, all of which had moderate quality of evidence. Moving away briefly from evidence quality, we had, of course, some other issues to discuss, one of which is, of course, vaccine supply, and we did have a presentation from MedImmune at the February ACIP about supply issues, so I won't be going into that here. Another issue is cost, as far as the relative cost of LAIV and IIV, we have not conducted a formal cost-effectiveness analysis for this particular effort. It's likely that would be a very complex undertaking at this point due to the very large number of different influenza products out there, of the different presentations. And in particular now we also have trivalent vaccine. It's probably going to be a couple of years before something like that could be done and we have a better sense of what is being used and also what the ratio of IIV to IIV4 use is and whether or not it reaches some kind of equilibrium. The work group decided that they did not feel it was necessary to have a formal cost-effectiveness analysis to move forward. We did look up the comparative U.S. prices per dose, and the data that we have comes from the 2014-15 private sector costs from the VFC, the Vaccines for Children tables. And for LAIV, this is Flumis quadrivalent. That's the only LAIV we have. It is quadrivalent. The whole supply is starting this season. And we have a price of $22.70 per dose. For inactivated vaccines, of course, there's a pretty broad range of variability. We have IIV3, we have IIV4, we have multiple presentations for each of them. And so we have a range of prices given for the trivalent $765 to $1481, and for the quadrivalent $1490 to $2109. We are aware of one 2008 cost-effectiveness model, which estimated cost savings of $45.80 per child with LAIV as compared with IIV, but it's really unclear to us what the applicability of this particular model would be given the current range of products, including quadrivalents, which were not yet around in 2008. So summary considerations for formulating recommendations. Key factor 1, evidence type for benefits and harms. The overall evidence type was 2 or moderate for efficacy and safety. Evidence is lacking for some critical outcomes such as influenza-related mortality, febrile seizure, Guillain-Barré, and immediate hypersensitivity. And studies might not be powered to detect some rare but serious events. As far as balance between benefits and harms, benefits appear to outweigh harms. There's modestly better efficacy of LAIV at an estimated 47 fewer cases of lab-confirmed flu per 1,000. No significant differences observed, at least in the data we were able to glean in terms of wheezing or fever. Value, the influenza work group placed a high value on the prevention of lab-confirmed flu. And cost effectiveness, there's uncertainty at present regarding the relative cost benefit given the currently available range of vaccines. So some limitations to all of this. For one, all of the published studies used trivalent vaccines instead of the quadrivalents. Quadrivalents weren't yet available. So now at present we have a complete supply quadrivalent for LAIV. We still have a mixture of IIV3 and IIV4. The quadrivalents were licensed on the basis of being immunogenically non-inferior. We don't have any reason to expect that the efficacy would be any less. From a safety standpoint, across the board, the safety profile seems similar. It is possible that there could be rare but serious adverse events that could turn up over the course of the years in post-marketing that would not have had adequate power to determine on pre-marketing studies. So this is something that's going to have to be followed, of course. Another thing is that it's unclear whether the greater relative efficacy of LIIV is sustained either with repeated vaccination over sequential years or with increasing age. Studies in adults have generally noted similar efficacy between the two vaccines or slightly greater efficacy of the inactivated vaccine. So it does seem that there's a point where something changes, but exactly where that is, we're not certain. So that is what I have for the first presentation. Dr. Tempty, I don't know if you want to do questions before we move on to the proposed recs or not.
We have time for a few brief questions. Or not. Why don't we go ahead and move along then?
Okay. All right then. Okay, proposed recommendations for the 2014-2015 season. This presentation is a little shorter, I promise, but the discussion might not be, I recognize. And fewer charts. The acknowledgements I'd just like to mention first, we have a very big group in the influenza work group, and of course I'm very thankful to them, and of course to Ruth, and also all my CDC colleagues who assist in putting all of this together. I would like to give special thanks to my grade teammates, Sonia Olson and Leslie Sokolow. Thanks, guys. I can definitely say we're never bored. So, proposed recommendations. The MMWR, just a little background, will be in the policy note format again for 14-15. We had a full MMWR R&R for the first time in 2 seasons or 3 seasons. For the current season that's just passed, we're going to be moving back to the shorter format for next season. The core recommendations really haven't changed. Annual influenza vaccination is recommended for all persons aged 6 months and older. We do have 4 new items that I want to highlight in the next few slides that are new and or revised. And those include the influenza vaccine virus composition for 2014-15, a minor change to the egg allergy language, a minor change in the pediatric dosing algorithm, and new recommendations regarding the use of LAIV and IIV for young children where either vaccine is available and appropriate. I've listed these here in the order which I believe they appear in the draft flu statement, but because we just covered the last topic, I'm going to move to that first. So given the information that I just presented and that we've been discussing within the work group for the last several months, we have some new proposed language pertaining to the use of LAIV and IIV for healthy young children aged 2 through 8 years. And the 3 bullets outline this language. First, we do emphasize all individuals greater than or equal to 6 months of age should receive influenza vaccine. Influenza vaccine should not be delayed in order to procure a specific vaccine preparation if an appropriate one is already available. Next, when both LAIV and IIV are available, LAIV should be used for healthy children aged 2 through 8 years who have no contraindications or precautions, category A. Last, if LAIV is not immediately available, IIV should be used. Vaccination should not be delayed in order to procure LAIV. That's the language for that particular change. Dr. Tempty, would you like me to move on to the other points and we can come back to these one by one?
Good question. I think why don't we pause there and just have some discussion regarding this particular issue, because I think this is the largest change. And we've seen this numerous times at previous meetings with grade presentations, but open it up for any comment or question. Dr. Reingold.
So this undoubtedly reflects my ignorance, but can you explain the difference to me between the first and the third statement, sir?
There is not a lot of difference, but we really felt it was important to emphasize this point. I will admit there is redundancy.
Dr. Bikini.
So what does this do for the second dose? If the first dose is with one vaccine and then that same vaccine is not available in a timely fashion for the second dose, is that included in that or need to be a separate statement?
We can clarify that in the recs if need be, and that's actually something to think about. But we're not proposing a change in the current recommendation, which is that each dose can be either. You don't have to have both LAIV or both IIV. It could be one or the other. So this would apply equally to both doses for those children who need to.
Dr. Brady.
I discussed this previously. One of the concerns that COID has is the fact that providers had already given their orders in February for the doses, and we were a little bit uncomfortable with two things. One, if you have this kind of preferential language which should be used, there could be some issues related to how families might respond if the pediatricians run out of the vaccine that should be used. And the other situation is, as you mentioned, we have been fortunately capable of immunizing much larger proportions of infants. And so now when you get to the 5, 6, 7, 8-year-olds, we're going to have additional children who've had multiple doses. And it may be that LAAV may not be necessarily a more effective vaccine in that age group. So the draft recommendations that we are sending to the AE board, instead of using LAAV should be used, we're going to use the language LAIV should be considered for healthy children to kind of make it a little bit less a kind of preferential.
Dr. Hahn, sorry.
Thank you, it's okay. Yeah, I just wanted to comment, I think that second bullet could just say when LAIV is available, it should be used, because it almost sounds like don't use LAIV unless you have both on hand. I mean, it's just a little odd. I think it could just say when LAIV is available, it should be used, kind of saying if you've got it, use it.
Okay.
Dr. England.
Janet England. I wanted to say that the first bullet actually might be applicable this year and the next year, as we still have some trivalent vaccines available. We've had confusion over the past year about withholding to get quadrivalent if you only have trivalent. So I think it's more than just LAIV and IIV. I like that first bullet. I think it's helpful to have it there.
Any other discussion? Ms. Pellegrini.
I'd like to raise the issue here of families who are going to be sensitive to the price point. And while the ACA language requiring insurance coverage of these vaccines is very helpful, there are still a significant number of families who aren't covered by those protections for one reason or another. Either they're in grandfather plans or they're in ERISA plans or things like that. And so I'm not sure I actually have a proposal, but I do want us to make sure we're thinking about the strength of this recommendation. You know, how strongly do we really, really want to push those families towards LAIV when for some of them that $10 price difference, or roughly estimating, may be significant or maybe play a role in their decision.
Dr. Bennett?
Aren't all those families covered by VFC, I believe?
No, not necessarily. I'm actually thinking about families with private coverage who aren't covered by the ACA protections, more than the VFC or the Medicaid families and things like that. Deductibles and all of that, right?
And Dr. Dushin?
Just on that point, somewhat related is the fact that we try to emphasize that both of these vaccines are excellent and effective, and that when possible, LAIV is preferential, but not getting LAIV is not a major disadvantage.
Any other comment? If none, Dr. Grosskopf, I think you could move along to the other points of discussion.
Thank you. There is some additional language related to LAIV. These include that a bit of a change to reflect the fact that some conditions for which we've recommended that LAIV not be used are to clarify that per the package insert, those are precautions. So that additional language spells out that LAIV should not be administered to those under 2 years or greater than 49 years of age, those with contraindications as per the package insert, which include those who are receiving, children 2 through 17 who are receiving aspirin therapy, and also persons who have had severe allergic reactions to the vaccine or its components, pregnant women, immunosuppressed persons, persons with egg allergy, children aged 2 through 4 years who've had a wheezing episode noted in the medical records or whose parents report that they've been told they had one within the last 12 months, and persons who have taken influenza antiviral medications within the previous 48 hours. The guidance further notes that other chronic medical conditions conferring higher risk of complications due to influenza are precautions to the use of LAIV, and per the package insert, the safety has not been established. The next point, vaccine strain selection for 2014-15. This had not yet been decided by the FDA. The WHO had met, but FDA had not met as of the time we last met in February. That committee, VRPAC, convened on February 28th, 2014, and for the 14-15 season recommended the same composition as the 13-14 Northern Hemisphere season, which is an A California 7 2009 virus, a Texas 50 2012 H3N2 virus, a B Massachusetts 2 2012 like virus, and for the quadrivalent vaccines, in addition to those three, a B Brisbane 60 2008 like virus. This is presented primarily for information, as this is what the composition of the vaccine will be for this year. Shall I move on?
Yes, please.
Okay. Now we moved on to the last two issues, which are relatively minor changes. One has to do with the algorithm for determining the number of doses needed for children aged 6 months through 8 years. Children in this age range, according to a couple of studies, seem to need 2 doses of vaccine instead of 1 the first time they're vaccinated in order to achieve an optimal immune response. This was a relatively uncomplicated situation until the 2009 pandemic, where we had to start also counting the doses received of the 2009 H1N1 antigen. For 2013 and 12-13 and 13-14, we had the same approach, which actually consisted of 2 approaches, both acceptable: a simplified approach, which considered only doses since July 2010, and a second approach, somewhat more complicated, but good for those who are in settings with good registry data that can be used, that considered all vaccination history, including the pre-pandemic period. For 2014-15, we're proposing keeping both approaches, that is the simplified approach and the complicated approach, but with the additional information that children in this age group who received at least 1 dose of the 2013-14 seasonal vaccine need only 1 dose in 14-15. And this is being done because the vaccine viruses are remaining unchanged for next season, and it's analogous to a change that was made for 2011-12, which was the last time that the strains were also unchanged for the previous season.
Is there any discussion regarding or questions regarding this? Oh, Ms. Groom.
Not necessarily a discussion point, but certainly just a comment. I know you said it was a minor change, but for those of us who are trying to program this into our EHRs and our registries, to have this decision come in June is very challenging. We definitely want to incorporate it because it will dramatically reduce the number of children who need 2 doses, but I'm wondering if in the future something could be included in the recommendation so that if there isn't a strain change, we can all assume that only 1 dose for these children would be made, and then moving forward we could anticipate this a lot sooner.
Definitely appreciate that. Unfortunately, since VRPAC and the WHO meeting tend to occur in February, we're sometimes somewhat stuck as far as knowing exactly what's going to happen with the strains. It may or may not be an issue going forward, because one thing that's under discussion, and I certainly can't say what's going to happen in future seasons, but as we get increasingly farther out from the pandemic year, this becomes less and less of an issue. So at some point in the near future, we will probably be discussing in work group whether we can move back to the simplest approach of all, which was last applicable in 2009, which was if it's your first time, get 2. Which didn't even require an algorithm, which was lovely. It just needed a sentence. But I definitely understand that point. We did have some discussion in the work group, and I don't know if Dr. Karen wishes to comment regarding the change and the difficulties that poses for registry programming. Okay.
I don't have a comment other than what you
Okay.
said, Lisa. But I agree that we may be going back to a simpler algorithm as those kids from the pre-pandemic time age up.
Dr. Gorman?
If we could go back to the slide, please. Number 6. Oh, 5. It seems to me on this list that you've changed some of the things that the FDA lists as precautions or warnings to contraindications, and I would like those to be separated out as you go forward.
Would those be things such as under the first bullet, the sub-bullets, such as pregnant women, immunosuppressed persons?
I don't have the list exactly in front of me, but
Okay.
there are providers who, in all fairness, are already using LAIV in some of those conditions.
We recognize that. We made an effort in the 2013-14 statement to make a distinction between those conditions that are package insert specified contraindications, of which there are really only 2, and those conditions which ACIP recommends against use of LAIV for. And there has long been a dichotomy of those conditions. For example, the recommendation against, probably the largest one, is recommendation against use in persons who have chronic medical conditions conferring a higher risk of complications from flu. And we attempted to make that same distinction here by citing that the first bullet is, of course, reflects the age indications. The second bullet reflects those package inserts that are package insert defined contraindications. And then the remaining bullets under the first main bullet should not be administered to are conditions that ACIP still does not recommend use for.
Well, then perhaps I would like to make a recommendation for language. Persons who the ACIP does not recommend receive LAIV, as opposed should not.
Dr. Middleman?
Amy Middleman from Society for Adolescent Health and Medicine. My question is similar in that on the bullet regarding the 2 to 4-year-olds who have had a wheezing episode, that almost makes it seem like adolescents who have a diagnosis of asthma aren't included in that. Unless I'm reading it wrong, it sort of implies that those who are 5 and older who do have asthma or who have had wheezing, it could be administered to them. Has that changed? Am I mistaken?
No, actually, no, that's a good point. I think there's an additional bullet I should have included here, but the draft guidance that the ACIP members have seen actually does include a bullet on persons of any age with asthma, and it looks like I've neglected to include that bullet on the slide.
Thank you.
Ms. Stinchfield.
Patsy Stinchfield from NAPNAP. My question or comment is on the same lines here, and it's related to those who write the vaccine information statements. Sometimes that is the only document that clinicians look at, and so we, I think in the past, have overstated who should not get LAIV, and that the current VIS says you should get a flu shot instead of a nasal spray if you have certain long-term health conditions. And so now that we've separated this out into precautions, I just want to make sure that the VIS writers carry that over and not overstate it there. Thanks.
Thank you. We will definitely, we've held off a little bit on the language for the VIS for next season, but because we knew that some things might be happening, so we will loop back.
And Dr. Moore.
Thank you, Kelly Moore with AIM. This actually kind of comes back to the first slide we talked about, because now that you've broken out who LAIV should be administered to and the precautions that are lower, on the original wording of when both LAIV and IIV are available, use the LAIV if there is no precaution or contraindication. And then we've talked about Chris Hahn's recommendation for just simplifying that statement, but I would like to understand what the intention of the working group is related to the use of LAIV where there is a precaution and it is truly not a contraindication. Are you saying that if there's a precaution for LAIV, you should, and you have IIV, you should not use it? But if you didn't have IIV, you just consider that a precaution? I'm unclear now about that distinction. Does that make sense?
Yes, I think
Sorry, yeah, barely.
I'll do my best. Please let me know if I miss the thread anywhere. But I see sort of two levels to the issue. One, I just want to clarify that as far as preference or any sort of preferential language is concerned, that at this point is strictly for healthy children and not for those with chronic medical conditions. With regard to basically the action step for precautions or conditions that would be deemed a precaution and aren't listed under the should not be administered to section. For precautions, those are situations that generally require clinical judgment and for which the benefits and harms have to be weighed. It's a difficult thing to make a statement about the relative benefits and harms in this particular case simply because for a lot of groups there simply are insufficient data. So at this point it's difficult to have a recommendation in a document that's intended to cover every possible scenario in the absence of that data.
Okay, so no preference if there is any precaution or contraindication in the patient, but then if they happen to have one or the other on hand, they can use their clinical judgment as to what the clinician prefers to use in that case. If the person has a precaution.
By the definition of precaution, that would involve clinical judgment.
Okay.
Dr. Kimberlin.
David Kimberlin, AAP Red Book. Could you back up one slide, please? If the language is approved as in the second bullet, should be used for healthy children, would that go on to onto the immunization schedule footnote as such? And the reason I ask is that if the AAP Board of Directors approves language of should be considered and the ACIP has should be used, we have a divergence of schedules after many years of trying to harmonize.
I don't know if there's anyone here who works on the pediatric schedule.
Dr. Shukat.
Yeah, I think that if a preference vote goes forward, the schedule will represent that. That the schedule is supposed to be clear for people. The footnotes would clarify, all the details, but it wouldn't be left invisible because that's the primary tool that clinicians have. So as you well know, you've been following a formal evidence-based discussion to make a decision of whether the evidence is going to go forward. And yes, it would be reflected in the schedule.
I therefore would put a plea that if the language that's approved by these two different organizations are not identical, we should hopefully be very careful about that because, again, many, many years have gone to getting us to the point where we are completely in sync. It'd be a shame, in my opinion, to go out of lockstep with each other.
Ms. Pellegrini.
Dr. Kimberlin, is my understanding correct that the AAP recommendation is based on the fact that we're out of sync with pediatricians' ordering schedules for the vaccines? So in theory, at least, our language would only be out of sync for 1 year?
I mean, I think that, yes, that's part of the discussion, and it would potentially be out of sync for only 1 year if there's no additional information to suggest that there may be a need to reconsider that.
Dr. Shukat.
For those with the long memories, I want to remind you that ACIP moved away from using the term should be considered based on AAP's strong recommendation that we do that. So,
that was based on whether or not something was going to be a vaccine that was permissive or not. But this is more trying to not place somebody into a situation where families might consider that if you're not doing it, that you're not doing what's best for their child.
Dr. Harrison.
I guess my biggest concern is that for a clinician trying to figure out what to do, I'm not sure what should be considered means.
The other point is I'm not sure when the right time is. If it's in February, people have already ordered. In June, people have already ordered. We're coming into the season. If it's October, we're well into the season. And there really isn't a good time. So And as part of the whole discussion we had with making recommendations and trying to codify the language, we really strongly try to move away from the should be considered, which is confusing to clinicians. Dr. Haas?
Phil Hasbach from Santa Fe Pasture. So just went over, first of all, from Santa Fe Pasture, a competitor. But as from a manufacturer perspective, a mid-season recommendation like this is pretty disruptive. So not only have they ordered, but what can happen is when this stuff goes out, then people will call up and cancel. We're already well into and almost finished with the major part of the manufacturing process. And I think there's not without precedent before that ACIP has given kind of a forewarning that something's coming in a outgoing year. So I think it was done with IPV, OPV switches. It was done when we first made the influenza recommendations down to 6 months of age. So I think that this is pretty disruptive to a number of stakeholders, EHR systems, et cetera, that will complicate things for us and it will have financial impacts on some of the manufacturers and perhaps some even healthcare practitioners.
Ms. Dinsfield?
Patsy Cintra from NapNap. Well, I'm just having deja vu here from our conversation when we went to a universal flu vaccine for everyone 6 months of age and over, and I think it was the same time of year, and we just added a term as feasible. So if you can roll this year, go ahead. If not, next year, but not to agonize or wait for a coming year. And in terms of Phil's comment, you know, if our vaccine rates were in the 80s, 90s%, I would worry about the disruption. But we have a long way to go to vaccinate people for whom IIV is available and they're eligible for. So I don't see the need to hold.
Thank you for the historic perspective. And also, when I look at my own state, especially in children 5 through 17, we hit about 30 to 32%, and that's the problem out there. Dr. Decker.
Santa Fe Pastor Michael Decker. AAP participants have noted that these studies comparing LAIV and TIV are sufficiently old and practice has changed sufficiently since then that it's not entirely clear if the benefit observed in those studies still obtains. And in that regard, I know you know that the manufacturer of LAIV has an FDA obligation to conduct an efficacy trial in exactly the group that you're proposing making this recommendation for, 2 to 8 years old. What I don't know, my question to you is, do you know when the results of that study will be available?
I do not.
Dr. Friedland.
Hello, Leonard Friedland from GlaxoSmithKline. GlaxoSmithKline certainly supports the use of evidence-based recommendations. I think the language that providers would like to see would be for clarity and understanding of the recommendation. So I think there would be value in the language to say that when IIV vaccines are used, they are safe and effective in this patient population. This language doesn't necessarily say that, so clarity that IIV vaccines are safe and effective in this patient population, I think would be valuable for the provider.
And Dr. Dushan.
Just to address the last point first, I believe the text, the annotated text, does describe both vaccines as safe and effective and very desirable. With respect to the timing, you know, this is an issue we've discussed at multiple meetings, that there is not really a great time, but we did try as a work group to signal our intent on this at multiple ACIP meetings. This is at least the third one where we've discussed this and given an indication that we're moving in this direction. So if you've been surprised by this, I'm sorry, but I think you may not have been paying attention to what we've been trying to signal.
Dr. Grosskopf, would you like to move on to the last little point here with the egg allergy?
I would be happy to. Okay. Vaccination of persons with severe egg allergy. We have I believe, minor change to this language. And just again, a little background. Since 2011, 2012, we've had this dichotomy between what to do with persons who have mild allergy, which we define as hives in response to egg exposure, versus severe allergy, which we define for our purposes as anything other than hives, any other symptoms besides hives following egg exposure. For the most recent round of the recommendations that we discussed a year ago, we also had RIV, recombinant influenza vaccine, come into existence. So the language as it currently reads is that persons with symptoms other than hives are recommended to receive recombinant influenza vaccine if it's available and if they're within the age indications, which is 18 through 49 years, or be referred to, quote, a physician with expertise in the management of allergic conditions. We have never specified allergist, but somebody with expertise in the management of allergic conditions. And this was a conscious decision out of the discussion that occurred out of the ACIP meeting in June 2011. Since we last spoke about all this, the Joint Task Force on Practice Parameters, which is a body that coordinates recommendations between the American College of Asthma, Allergy, and Immunology and the American Academy of Asthma, Allergy, and Immunology, ACAAI and AAAAI, respectively. In 2013, John Kelso and Matt Greenhot authored a very brief paper which cites a 2012 review, which is actually one we discussed at our last meeting last year, of over 4,000 patients, including 513 with a history of severe allergic reaction to egg, and no occurrences of anaphylaxis were noted, although there were some milder reactions that occurred. That particular document recommends that special precautions regarding medical setting and waiting periods after administration of IIV to egg allergic recipients beyond those recommended for any vaccine are not warranted. Now, we did have some discussion of this document within our work group, and there were a couple of concerns which emerged, one of which is that we are still seeing occasional cases of anaphylaxis, possibly due to egg, that are reported in VAERS. The particular case that was noted in our excellent safety review presentation today, as Dr. Kano noted, the authors believed was due to gelatin rather than egg, but we did have one anaphylaxis case which was discussed by the CISA hypersensitivity work group last year that was believed to be due to egg in an egg allergic child. There was also some concern that we have, of course, a very wide range of settings in which influenza vaccines are given these days, and that not all such settings, even though they should, and it's in the general recommendations that they really should, have appropriate equipment and personnel available and ready to go in the event of anaphylactic reaction to any vaccine, regardless of a patient's history. There was concern that this might not be the case in all situations. So the new language seeks to clarify that a referral is not strictly necessary, assuming the person who's going to be administering is a physician with expertise in the management of allergic conditions, and also does maintain the 30-minute wait period. We have not made a change to that. I'm going to just review the specific language. The proposed change is that persons who, persons who report having had reactions to egg involving such symptoms as angioedema, respiratory distress, lightheadedness, recurrent emesis, or who required epinephrine or other emergency medical intervention, particularly those that occurred immediately or within a short period of time, minutes to hours after egg exposure, may receive recombinant influenza vaccine if aged 18 through 49 years, and there are no other contraindications. If RIV3 is not available or the recipient is not within the indicated age range, this is where the change clause comes in. The current guidance is such persons should be referred to a physician with expertise in the management of allergic conditions for further risk assessment before receipt of vaccine. We propose changing that clause to IIV should be administered by a physician with experience in the recognition and management of severe allergic conditions. I believe that's the last change. Oh, yes.
Thank you. Further discussion here. Dr. Jenkins.
Yeah, it's just a minor edit. It said should be administered by a. Is there a word missing?
The by is missing.
Oh, administered by. Sorry for that error. It shall be corrected.
Dr. Dushan. Oh, Dr. Dushan is making a motion to Would this be including the antigen, the current antigens, the language here in allergy, the recommendation for Live-Attenuated, and hopefully I'm paying attention here, the and the dosing for children?
Yes.
Okay, so
A package.
we have a motion, and Dr. Kemp.
Actually, can I just annotate that with the clarifications that were suggested regarding the licensure information and the ACIP recommended contraindications and precautions.
Okay, and Dr. Kemp?
And the perhaps different wording about the fact that IIV is safe and efficacious, but LAIV may be more effective, essentially, in that.
Do we have a second? Dr. Harrison. Further discussion? Dr. Rubin.
If we could just go back to the slide about LAIV.
There.
Suggestion is, given some of the comments related to the second bullet, and changing the first phrase to just say, when feasible, comma, LAIV should be used rather than the current text. May take care of at least some of the concerns with price, availability, and so forth.
And that would make it consistent with what Ms. Dinchfield had mentioned about that switch to universal. Is that all acceptable to?
May I ask for clarification?
To change when both LAIV and IIV are available to say when feasible in the second bullet.
I would say that that's implied. I mean, all of our recommendations are when feasible. I mean, none of them can be implemented when not feasible.
Dr. Kemp.
That's true, Jeff. But I do think that particular wording here might be helpful in lieu of the fact that people might find themselves in a bind for the next year or so, and I don't think it hurts.
So what about, instead of putting that into the formal recommendation, to annotating the guidance with that type of information, as is frequently done when the recommendation comes out, there's a statement that can put it into some context that would explain the timing and some ordering issues and the fact that this, might be a little challenging the first year, but people shouldn't feel bad about that.
Along that line, a statement to the extent that understanding that orders have already been placed and so on, this is a recommendation as is feasible, and then go into the recommendation. Okay, Dr. Bennett.
Yeah, I think the objection to that first clause, when both LAIV and IIV are available, was that it sort of implied you had to have both in the office before you gave LAIV. And I think that's what we were trying to get away from, is just phrasing that a little differently.
Dr. Curran.
So I think the phrasing that was suggested for that was when LAIV is available. That does not, which I agree with, because I think it just makes it much cleaner and simpler. It does not get to the feasibility issue, but I have to say that I agree with Jeff that perhaps that could be annotated rather than going into this primary language.
Ms. Pellegrini.
I'm going to push just a little bit here. There are multiple aspects here to feasibility. In fact, I think there are probably even some we haven't talked about here. And it goes back, I think, to the core question of just how strong is this preferential recommendation? Are we limiting it to a small universe of feasibility issues, or are we broadening it to things like family preference, economic considerations? So there are some of these feasibility concerns like the transition year that are going to be short term. There are other feasibility issues that are going to be longer term or that are going to be evergreen. So there's a larger philosophical question here, I think.
Dr. Kemp?
I think that's very true. And in fact, I can think of a lot of children who, for some strange reason, prefer the injection. And I, as a doctor, am never going to say no because I want them to get it. And I think those things will always be there. But I think maybe it would help to word these in terms of the data. So first of all, both LAIV and IV are efficacious and are effective and what?
Safe.
And safe. Thank you. And secondly, their data suggests LAIV may be more effective in healthy da-da-da, therefore, that should be a preference. Or, I'm not getting the word exactly right, but let's just stick with the facts. And then I think should be used is a little bit too encompassing and doesn't really incorporate what we're trying to do, which is evidence shows this.
I guess I'd like to comment that the additional language in the recommendations actually goes through the evidence and talks about the data. I think it's rather cumbersome to actually include that here. I can just tell you from the work group's perspective, this has been a long time coming, and there's been a lot of discussion in the work group, and I think the feeling of the work group was that the language was, we specifically chose the language should be used after a lot of deliberation and review of the data.
And that's based on moderate to high quality evidence. Further discussion, I'm going to go back to, I think it was Dr. Dushin who made the original motion, and we've talked about some subtle changes to that. Are those acceptable to you?
Yeah, maybe we should just, which ones? I think that if Dr. Kemp agrees, the issue of feasibility and the issues around timing can be discussed outside of the recommendation itself, but in the annotation in the context. And the suggestion to modify the second bullet to when LAIV is available, it should be used, is acceptable.
And that corresponds to the third bullet point, when it is not immediately available. And those dovetail nicely together. It may, Dr. Pickering had a good point. It might be nice to have this written on the screen so we know exactly what we have. Dr. Savoy.
Margot Savoy, American Academy of Family Physicians. I just had a question about, would people feel better if there were a job aid similar to what we were shown earlier today that was more specific around with the table that sort of had the arrows that was like, if you have this, then give this, if you have this, then give that? Because I think if I had just read the text of what was written, I would have assumed that if I had both, then I'm supposed to give the live vaccine, and if I don't have both, then I give whichever one I have. But if other people weren't going to assume that, if our worry was that people would get confused about which one, or that if they had one, they wouldn't give anything until they got the live in, something like that job aid might actually clarify it without having to change your actual recommendation.
Dr. Coyne-Beasley.
I'm sorry, I just want to say very respectfully that we're like 25 minutes over, and I want to make sure that our adult work group does not get bumped again. It will include a discussion. I'm so glad for the laughter, because I really want to make sure that our individuals get an opportunity to present this time. Thank you. And it will include influenza also.
Let the record show that at last meeting, I promised you that that would not happen, and you will have your time this afternoon. Dr. Brady.
I would agree that probably from the perspective of what I mentioned before, if that second one was changed to if LAIV was available and didn't include both, then if a pediatrician didn't have any LAIV, then that would kind of give them a easier out.
Thank you for that clarification, Dr. Bocchini.
No, and I would agree with what Dr. Brady said, but I think importantly, this is a one-year statement. So just like the AAP statement, this is only going to be enforced for 1 year. So it's okay to kind of make an interim change with the language that was mentioned and then change it again next year based on the fact that people are more ready for ordering in a different way.
Okay, so with what you see up there, Dr. Dushan, are you, as the maker of the motion, is that acceptable?
Yes, what I see up there is acceptable.
And I'm trying to recall, was it Dr. Harrison who seconded? Oh, no.
Yes, and yes.
The actual language was both IIV and LAIV are considered safe and effective, period. When available, LAIV should be used. I think that was actually the suggestion that was.
That's in the prelude to the recommendation, so that will still be in the statement. Okay, so we have a motion and reseconded. Okay, so reading into the minutes, use of LAIV and IIV for healthy children aged 2 through 8 years. All individuals greater than 6 months of age should receive influenza vaccine. Influenza vaccinations should not be delayed to procure a specific vaccine preparation if an appropriate one is already available. When available, LAIV should be used for healthy children aged 2 through 8 years who have no contraindications or precautions, category A. And then if LAIV is not immediately available, IIV should be used. Vaccination should not be delayed in order to procure LAIV. Dr. Curran.
Sorry, in the third bullet, it should just say if LAIV is not immediately available, there's an "it" in there that should not be there.
Thank you for catching that. My mind went immediately over that. Further discussion? Seeing none. We will start with Dr. Harrison, proceed in a counterclockwise manner, which would be to Dr. Vasquez, I believe.
Yes.
Vasquez, yes.
Coin Beasley, yes.
Harriman, yes. Jenkins, yes.
Kemp, yes.
Go, go, go. Keep it going.
You got my vote? Okay.
Reingold, yes.
Fuchin, yes.
Karen, yes.
Capasal, yes.
Tempte, yes.
Bennett, yes.
Pellegrini, yes.
Rubin, yes.
And the motion is carried unanimously. It's amazing how 5 hours can pass when you're having fun. But we stand for break.